rounds with myself as the moderator, and I'm also the faculty lead for simulation education integration here in the Temperley Faculty of Medicine. This is our second SimCity rounds for the year, and we're wrapping up the year, but my hope is that next year you'll be invited to many more of these. I'm truly excited to introduce to you Dr. Douglas Campbell, but before I launch into his impressive bio, a couple of housekeeping notes. We are recording this session so that we can share it with those who are unable to attend, especially our surgeons and all those who might be in the OR or otherwise occupied. We will ask you to please keep yourselves muted, but feel free to keep your cameras on so Dr. Campbell knows how excited and interested we are in what he has to say. It's always a bit discombobulating to talk to black screens. Also, I will ask that there is going to be a Q&A interactive portion, so please unmute yourselves, put questions in the chat. I will be monitoring the chat so that we can make sure you're heard and that we have a very active and lively discussion. So Dr. Campbell is the director of the Neonatal Intensive Care Unit and the Deputy Chief of Pediatrics at St. Michael's Hospital. He's also cross-appointed to the Hospital for Sick Children, where he works as a staff neonatologist. His academic interests include the use of simulation as a toolkit for healthcare organizations, neonatal jaundice, and neonatal nutrition. His academic rank at the University of Toronto is that of an associate professor within the Department of Pediatrics. He's also appointed as an associate scientist at the Li Ka-shing Knowledge Institute at St. Michael's Hospital, and that's related to his wonderful work in simulation. He's a past member of the Canadian Pediatric Society National Resuscitation Program at the Executive Committee, and he's the past chair of the Canadian NRP Research Committee. He's the medical director of the Alan Waters Family Simulation Center at UHT, and he's received simulation training at Stanford University at the Center for Advanced Perinatal Education. He has international recognition for his work in simulation, and he's been elected to the board of directors of the International Pediatric Simulation Society and the inaugural simulation lead for the University of Toronto Faculty of Medicine. Thank you so much for starting us off, and I'll now hand it over to you, Doug.
Thanks so much, Petal. I was saying to Petal earlier, it's always best to go first because then expectations are zero, not even low. So that's hard for me to fail. So thanks for attending. I know the time is always hard for so many of us, and thanks for that introduction, Petal. You know, there's a lot of titles and accolades, but I'm definitely surrounded by lots of great people, and it's so nice to see familiar faces. Maybe I'll start sharing my screen. Oh, I'm not able to share my screen. Can someone help me share my screen?
Ricardo, we need to give him permission. You're a co-host.
Done. Please try again.
Okay, perfect. That should work. Can everyone see that? Great. So please interrupt me, just unmute yourself or send to the chat. And thanks, Petal, for monitoring the chat. I don't have 100 slides because I don't want to put everybody to sleep, and it's lunchtime, and so we have to be thoughtful. But I thought it would be useful to sort of have a journal club format as a starting point. And I think Petal will share with us her vision as time goes on in terms of the purpose of these rounds. But I thought we'd look at a journal club as one way to kick us off. And it's so great to see everybody and really interested in people's thoughts and ideas. So please stop me or comment at any time and we can have discussion. So rapid cycle deliberate practice is the new gold standard for resuscitation and simulation design, especially with teams. And you know, this article came in Simulation in Healthcare, and it resonated with me for obviously my biases. It may not apply to many of you who are on the call today, but I thought it was worth discussing, and hopefully people find it an interesting place to start. So a little bit about me. I was lucky enough to stumble into simulation when Vern Nake was the medical lead of simulation at St. Mike's, and he got me interested, as well as my neonatal training and education. And you know, things have changed a lot. I was really blessed, I think, to take on the SEAC, faculty of medicine lead at U of T. It helped me get to know the community better. I know so many of you for different sim strengths and expertise around our hospital, but it really helped me understand a little bit more about where we're at. And I think the sim community is very much a community, maybe more so than many healthcare professions. And I really hope one of the purposes of this talk is to keep that going. So I have a clinical interest in babies, obviously, and sick babies and neonatal intensive care. And so even though all of us have our very specific focus, whether it's clinical or research, I do hope some of this talk will be of relevance. I've always thought of sim as a learning tool versus a teaching tool, and I starting to use this sort of title now moving forward, because whether we're faculty or learners, whether we're nurses or ward clerks, whether we're sanitation and department members or whatever, or even fathers and mothers and partners, simulation is a way, hopefully a safe way from which we can learn and teach. And I think so many of us on this call realize this. It's not really necessarily a methodology for teaching, although it's great if that happens, but I really do believe it's a way we can all learn. And so this is the article. Hopefully some of you had a chance to read it. But it came out this year, and I thought this was a really interesting place to start. My focus initially in my ongoing clinical work is with resident education, and the pediatric group in general in North America and in the world has been one of the leaders in simulation education research, and so this is no exception. And maybe I thought let's try to bring some people together, and many of you may not know about this topic or this technique. So where are we? Well, currently team training doesn't always prepare clinicians adequately for emergency situations. And so this isn't just physicians, of course, it's the team. And we know that there's lots of good theory and educational principles that are really involved to make teams better, to make individuals better, to make individuals within teams better. So these are things that are very commonly talked about and well studied, such as direct feedback, mastery learning, having the opportunity to become better and better and better. And appropriate in situ learning, so contextual learning to allow us to improve. And so this is obviously an ongoing effort, and despite the modern simulation integration into healthcare education in the last 50 years, I think we still struggle, most of us as learners, to in whatever profession we're in, struggle to become experts at the end of our training. And how do we continue to improve, and how do we deal with things while we're also dealing with the COVID pandemic and all our own issues? And so I think this article is one way to think about that. We know that improvement of skills has been demonstrated when using simulation-based teaching. We know with multiple healthcare professionals, it's harder to understand this research. It's harder to do this research, and it's not frequently studied. So a lot of the focus, even on this article, is a focus on a resident leader of a team, when that's not always necessarily the point, depending on your clinical context. And furthermore, non-technical skills training, such as leadership, is also infrequently studied. Yet time and time again, and in multiple settings, is considered crucial to improving team performance. I was at a debrief yesterday Monday on our floor after a code. And again, leadership from our nurses was highlighted as an area that needs more training. We need more leadership, we need more anticipation, we need more guidance. And how do we teach that? How do we focus on that? Even though we're all of us are assessed so many times as trainees and hopefully as staff, how do we improve this? And therefore, how does that affect team performance? So this article sort of talks a little bit about comparing two common ways of a scenario-based team training. And for many of us, certainly in the pediatric world, many of us will choose two general approaches. Adam Chang was lucky enough to teach as a junior resident a long time ago at SickKids. Is clearly one of the pioneers of simulation research internationally, and him and his and Walter Epic and others put together a PEARLS methodology that many of us might use. So after you train your team with hopefully a well-designed scenario, you have this reactions and description analysis and take-home message approach. But what about rapid cycle deliberate practice? I first came across this method when I happened to be sitting in on a bunch of adult emerge guys doing sim at St. Mike's. And one of the things I love about my job is that I get to learn from other professions and other, where I may not have been able to learn about this since I was often clinically based in my NICU world. The silos, unfortunately, continue. So, this is one of the dilemmas, and the part of this article's purpose is to try to tease apart this type of dichotomy in many people's mind in terms of scenario-based team training. And for those of you that may not have used rapid cycle, the idea is to provide short scenarios from which you can give very directive feedback, and then allow the learners and team to then work through a longer period of that scenario. Again, stop them, give feedback, rewind, start again, and go on and on and on, so that the feedback is multiple. It's hands-on. They get a chance to try again. And many of us use this because especially for skills-based learning, it seems to be very effective and provide sort of quick hits. Maybe I'll just start with a quick poll, and hopefully the Slido works. Hopefully, if you guys can get your phone and hit the QRS code or go to slido.com, you'll see a number here. I'd be interested to know whether you guys as an audience today use these two techniques, either one or both. So in terms of your scenario-based simulations, do people use the typical debriefing at the end? There we go. We got live action. That's what I like about Slido. You can see where the group is already. Let me just try to move the screen around. So a lot of people use both, which is interesting. Yeah, not very many people use rapid cycle, at least people on this call. It's maybe not representative of Canadian team training resuscitation, but so a lot of people use both. So that's really great. So hopefully then this article is of relevance, because I use both when I teach or when I participate in learning activities. So that's great. So hopefully I was lucked out that this might be actually of relevance. So let's talk about rapid cycle. I think this was really first best described by Betsy Hunt in 2014. Lemke, who's one of the authors on this paper, picked up on it. And as I mentioned, it's this idea of providing recurrent direct feedback for a team that's going through perhaps a novice performance, and then improving or increasing either the length or the difficulty of the task, the scenario at hand, and giving more feedback, so that the idea is that you then have mastery performance, at least in the scenario that you're studying. And so this cycle continues. I thought it was useful to contextualize it a little bit better. And I'll talk a little bit about our own journey here at St. Mike's and in the neonatal world, because it was an eye-opener to me as I started to use this methodology a bit more. So what does the literature say around rapid cycle deliberate practice? Is it better than scenario-based simulation with debriefing? This review last year suggested that there's not a lot of evidence. There's not a lot of studies that have looked at this. When people try to look at rapid cycle, it's not really as a learning tool or as a team-based tool. it's not really compared to many other methods. So there's not that standard group or control group. So although it helps learners, especially with skills and task completion, how do we know it's the right one? In which setting do we use it? For which team do we use it? Like many things, it probably comes down to your learners, where they're at. And we often struggle, I think, to try to understand where is our team at, where it's often, hopefully, they're interprofessional groups. And so that might be one reason. Interestingly, rapid cycle seem to be good at retaining skills in many studies up to 2 months post sim activity. But there were some studies that suggested there was maybe some harm in retention. I think that's probably more to do with the study design and the difficulty in understanding performance over time and the logistics of doing those type of studies. The little work that did exist comparing rapid cycle traditional sim learning, so there was actually no change in teamwork scores over time. So this question that these authors brought out, I think is relevant for those of us that do team training. So this is a snapshot of us trying to improve our neonatal team performance. And just to give you a little context about where our journey was, we developed a sort of version of rapid cycle deliberate practice, and I have to send big kudos to my sim team at Unity Health and St. Mike's. This was the large part of this work was done by our educators within our program and our sim specialists who really sort of helped lay out this methodology, because it has been described for neonatal work, but it's infrequently described. And so we were interested in this because there was a bit of apathy with our current Code Pink sim training program in our organization, and said, well, what else is there? And so we developed a template so that clinical experts or instructors who pair with our sim program could then do in situ rapid cycle training with our actual teams. And we developed it in such a way that we really ran only 3 or 4 cycles. One was waiting for a delivery, for example, if a baby's about to be born and there's a pediatric team there ready to help the baby, assuming the baby is going to be sick. The first cycle was going to focus on role assignment, equipment checking, etc. And then it would stop very soon after the baby was born, with feedback around those specific objectives. Our second cycle focused more on subsequent steps of neonatal resuscitation, which is pretty standardized educational course. Was positive pressure ventilation on the baby done well? Was there a Mr. SOPA review? Was a decision made around intubation? Was monitoring done? And so we stopped it there after the teams got to rewind and start again. And then we'd give more feedback. And then the third cycle where we'd start again. And this is the third cycle, by the way, is where we'd often bring in other learners or other team members who were watching. And we'd run it through the compressions, epinephrine. So if we had time for the session, we often do a more traditional debrief at the end. So we developed this team, this rapid cycle template. And this was around 2019, because after there was this apathy, and as part of our SIM program, we sort of do regular audits of our activity. And a program audit showed that, especially our allied health team members weren't happy with how the Code Pinks were going. I mean, everyone's happy, right? Satisfaction is such a low-hanging fruit, but they felt that there wasn't enough opportunity to practice skills. So if you spend 10, 20 minutes doing scenario and then you have a 40-minute debrief situation, our allied healthcare team specifically found this wasn't helpful to them. These were all in situ sims, and I think they felt a little bit stressed and pulled away from their activity. And if we weren't really meeting their objectives, then why would we continue? So we switched. We switched to this rapid cycle template after lots of work from our sim program, looking at feedback, and we tried it, and we redid the template. And we actually added role-specific skills practice stations prior to doing these in situ sims, so that different team members could huddle within their own group and have some skills specific to their group. then we tried to look at performance and try to understand a little bit about the feedback. Was this new methodology helpful? And so what we did is we just video recorded these in-situ code pinks following the change, and we tried to understand how was this working. And again, this is all sort of program audit type of specifics. And at Unity Health, at St. Mike's, and at St. Joe's, we definitely are a big fan of interprofessionals. We won't run these without nurses and RTs coming, because it doesn't really help our learners, our medical students, or residents, or staff who participate either if they don't have the team. And so we looked at a few sims following this switch to try to see how we did it. And just for those of you who are interested, we often have a lot of people come to these codes, and how do you incorporate all of them in a timely way? So we'd layer people in the various cycles, because we thought that was at least a way for people to get involved and to get hands-on. That hasn't really been described a lot, but that was what we did, because it seemed logical and feasible and got everybody going. And what we, this is just a simple sort of feedback sort of from our evaluations. And this was, I think, the 2019, when we asked people what they thought of their code pink, these words sort of came to mind. And then when we switched to the rapid cycle, some of those themes were continued, but there was certainly more emphasis on skills, actually. And I thought that was interesting. Our satisfaction scores were still high, but I thought this display of words showed us that there was a different emphasis, and it makes sense. When you do a rapid cycle deliberate practice technique, people are going to get feedback on skills. So this sort of came back to us as maybe we're on the right track, but we'll see. Maybe in 2 years we'll abandon this as well. Who knows? But it's a challenge for new instructors to learn, and how do you do it well? Like anything, it's an ongoing issue for us. So when I saw this article, I thought, oh, this is relevant to me. Hopefully it's of relevance to you guys, and happy to chat more about our specific strategies afterwards. So if you look at this article, it really looked at PEDS resident learners working in teams. And they compared, they took advantage of existing simulation teaching opportunities in their residency program, and they streamed residents, and they randomized residents actually into a rapid cycle sort of practice, or did they do the typical post-simulation debriefing? And they videotaped performance within a team within 12 months after their initial randomization. And they wanted to look at PAL skills. This was a pediatric emergency curriculum sort of objective. And they also wanted to look at team leader performance. So this is really the nutshell of this study. And for anyone who does this research, and I'm not a researcher by any means, I do dabble in a little bit, and I find smarter people than me if I do research to help me. But this is a big program. I think it's in Houston, this group, but they had a lot of participants that are eligible, a lot of residents eligible over the time they ran this. And they randomized approximately 130 people to each group. But they lost 86% to follow-up, but that happens, right? In sim-based educational research. There's always flaws in these studies, but when they brought them back, they looked at their tools, and they did power it for skills-based scoring, and they only needed 16 in each group. So they did have enough for their primary outcome. And they did work within teams. It's very challenging to bring back the same team members to understand team scores, and other people are probably more experienced than me. I tried doing this when I first got into sim research, and it was impossible. You can never get the same team members back 3 months later or 6 months later. Just logistically, even if you paid them, it's very hard for people to show up. 3 months from now on the same Tuesday and see how the team performs. So this was really an analysis of skills and leadership for residents working within teams. And the outcome was a standardized team. And so let's look a little bit more closely at those learners that came back. And these were pediatric residents mostly. Some of them were specialty residents, but there wasn't a difference in who were randomized, at least based on these characteristics to each team. These were mostly PAL certified PGY2s. Almost all of them had previous SIM experience. And between the time, and all of them had attended codes. And so there was a relatively similar distribution, at least on the face of it, in terms of which types of residents were randomized to this type of teaching. You know, and whenever we do journal clubs, we try to, especially for a randomized study, we try to think about these type of questions. And the learners were randomized in this case. The groups were similar based on demographics, but it was interesting. The paper didn't really talk about, or at least I couldn't see when on average did each of these groups come back. They sort of described that 40% of everybody came back within 3 months, and another 25% within the next 3 months, and then a third of them came back between 6 to 12 months. So I wasn't sure if each of them, whether each group was different and when they came back or not. It wasn't really clear to me. That they had a relatively similar strategy, though. It was bring a bunch of residents in for initial training, give them some learning, randomize them to either method, and then bring them back with a standardized team. So that was a pretty consistent course of learners. And were the outcomes blinded? And actually, they did a good job. The learners were aware of which group they were randomized to, obviously, but the evaluators didn't know, and skills and performance was blinded. And so was follow-up complete? And yeah, it was for the 16 that came back. You know, the 80% that didn't, you wonder if they were different, were they representative? You know, and so we don't know that. And the outcomes in terms of skills, they looked at pediatric resuscitation. Always bugs you. It's a lot easier than neonates. You just have to shock them and the patients come back, right? That's not that hard. Babies are a lot more complicated, but I'm joking, of course. So the task and time to completion, so defibrillation is a very standardized sort of skill outcome measured in pediatric resuscitation. And it seemed that, you know, perhaps not surprisingly, that those that were randomized to rapid cycle did better, and quite a bit better. And that's been demonstrated before, that retention of skills. It's interesting. I would have liked to see sort of how long this skill set was retained within each group. And if you look at the time elapsed from the onset of this unresponsive child to defibrillation, those in the rapid cycle deliberate practice group did it sooner, and they did it better. So this by itself, I think, is an interesting study. This methodology, you know, for a skills objectives, especially something as important as defibrillation, time to shock to bring back an unresponsive patient in VTAC, is pretty impressive. And then what else did they look at? So they looked at, you know, in terms of time to shock. So there was no difference, sorry, in terms of time to shock, but within 3 minutes, the rapid cycle group did better. The washout period was similar. The time to CPR was suggested to be better in rapid cycle. And then they used this leadership score, which I'm not very familiar with this RTLE score. I'd be interested in others as well. And what that interestingly showed, that within standardized team after the initial randomization, they did do better if you were in rapid cycle deliberate practice. And so that's kind of an interesting question, is those that were given the opportunity to have a rapid cycle teaching, why would they become better in leadership retention wise? So that, I think that's worth maybe talking about. And so I always like to think, is this a generalizable study? Does it help me where I am? Again, this was very focused on the resident as it, knowing that it's hard to bring back teams and see how teams improve. It suggests, though, that residents, even with a different team, seem to do better with one methodology for another. That's what it suggests to me. Obviously, we'd like to see maybe is this an adaptable type of teaching for other professions? I'd be interested to know, for those who, like so many respiratory therapists or nurses, end up leading resuscitations in different settings, even for a short period. Would this type of practice help them in their skill set? And does this method help make better teams? We don't know that. They use confederates to assess, as to standardize the teams for which the residents were then brought back to work with it. So does this type of, even though it works with simulated resuscitations, it seems over time, does it work in real world teams? Always the big question with sim studies. And as we mentioned, can we make sure the other professions improve? I might just pause there. I think I'd be interested to know from all of you whether you agree or disagree with some of my statements, and what else struck you about this paper. Maybe I'll pause there, Petal, and open it up. So love to hear your comments. See how far off I am.
We have Jordan. Jordan's hands up.
Thanks, Petal. Thanks, Doug. That was super interesting. I think really nicely synthesized as well. I think the thing that really pops out for me about this debate, if you want to call it, between kind of post-simulation debriefing and rapid cycle deliberate practice is, I think when we have a conversation about what kind of expertise are we trying to build, it seems to me that rapid cycle deliberate practice seems completely appropriate for the kind of training that they're looking at, of developing mastery in a known problem space with like a direct application, and your logic is about improving efficiency, time to defibrillation, and those are the key goals. I think where I would have a little bit more pause in saying, like, yes, let's do rapid cycle deliberate practice for all kinds of scenarios, is the degree to which we're looking at things like responding to uncertainty or the degree of complexity that we're working with. And it would be interesting to do this research, and I guess my bias would be more towards post-simulation debriefing, of being able to uncover frames and dig more into the cognition piece and the sort of clinical reasoning piece, which I think might prove to be more consistent or coherent with building those underlying knowledge structures that would be appropriate for responding to uncertainty. But I think it's a really interesting debate and research space.
Thanks, Jordan. I have two other hands up, but I noticed Tim typed in the chat, curious about economics here. Is either approach more efficient in terms of cost or resources?
Yeah, that's a great question. Maybe I'll just comment on Tim's question, and thanks, Jordan, for those comments. I agree with you. I mean, well, I'll start with Jordan's comments maybe first. The skill stuff makes sense, right? If your objectives are improved skills, especially with sort of deliverables like time to shock or time to intubate, it kind of makes sense. I agree. And I think this is what interested me, is this look at the suggestion that your team might be better, right? And although this study was focused on leader performance using a tool, it clearly doesn't answer that question, but it was one of the first ones for me that suggested maybe it does influence how a team learns. So I really value that feedback. Thanks on that. Tim's question is an interesting one for lots of reasons. I think it probably, the efficiency and the costs, right? Like, what type of activity are you running to begin with? Who are the participants? What are the costs, whether it's financial or time or whatever, of your participants? Is interesting in our own experience. We've been more efficient, it seems, at least. We don't have a lot of data on it, but in terms of running these sessions, it seems to me that it's quicker. Now, it'd be interesting to know in terms of, because we do a lot of in situ sim, so time is money for us. So because we can't pay people to participate in our team training. So I think it matters. 10 minutes matters probably. If you're saving 10 minutes, that probably matters to a lot of participants and staff, because these are all staff people. And so I think it's a really interesting question that we haven't looked at St. Mike's. I don't know if other people have looked at or other comments.
So Agnes's hand was up, and then Fahad also commented, I'm assuming it adds time to the total duration of sim sessions as well.
Yeah, and Fahad, for us, it hasn't. I mean, I think people still always argue that everything goes too long. When you're doing in situ, it takes time. But for us, when we looked at least a few of the time to completion of the session was not any different. But that's a very small sample, so we may be out to lunch on that.
Ricardo, can you stop sharing the slide so we can see everyone? It'll be easier for
me. Oh yeah, I'm gonna stop.
Okay.
Yeah.
So Walter, welcome. Thank you for coming. Walter commented, I wondered about what is lost in the process of rapid cycle deliberate practice. Any insights on that?
Yeah, so for me, I think, there's a risk, I think, with rapid cycle of losing the reflective frame of reference learning, right? That many of us incorporate into our typical debrief. I don't know. I'd be interested to see how people run these things. I always think, on paper, it's run theoretically like one way, but in reality, how do we actually run these sessions? I think I use still a blended approach when I use rapid cycles. So I try to pause and get into the frame of people's brains within each cycle. I try to do that rapidly. Don't know how effective that is. And I don't know, as others run this, whether they found they start to flip into that more sort of traditional debriefing style. In terms of as for Jenny Rudolph and Adam, and trying to understand where people's brains are at with certain observations. I find I do that, or if it's depending on the learners, if it's direct feedback, I then might do a little bit of an exploration of that at the end if we have time. So I probably end up doing a combined. So again, maybe that's hard to do, maybe that's unrealistic. Interested in others' thoughts.
Agnes?
First, Doug, thanks so much for a wonderful presentation. It's always nice to hear you speak. So thank you. I want to share what we do. So we do a little bit of a modified practice of that, where it's not 4 to 5 minutes. We're not that prescriptive about it, but where we found a lot of positive feedback on applying it, and to your point, Walter, is we do a 2-day approach, and that's for internationally educated nurses, and it's for building skills. So it's not for individuals that are coming in just to refresh or to practice something that they already know. It's to build brand new skills, such as head-to-toe assessment or a transfusion reaction, and how to deploy your team and work within your team. And when we use it, the following day, we give time for reflective practice. And when we start the next day with exactly the same group, that's when we do a little bit of that reflective practice. What was it that was percolating after yesterday for you? And what are your key objectives for today? And modifying with that. And then we flow with that approach. And we found it works really well to help build new skills, because you're repeating again and again. And you're stopping at a point where people are not, or folks are not feeling almost like that failure. Oh no, we killed the patient. Like you're mitigating that, and you're building confidence, especially with new skills. When we used to say, bring people to the cliff, but not over the cliff, so they don't feel like they fell off. So we've had positive aspects with applying it in that context.
Sorry, there's some banging on my end, but I wanted to add that our Sim Center at CAMH are also experimenting with the rapid cycle deliberate practice. So we have contracted a subject matter expert, Aliyah Daramsi, from your side of the fence, Doug. And so she's introduced that to us. So our physicians, you know, many of them are not on call very frequently because there's over 200 psychiatrists at CAMH. And so there was a lot of anxiety around being on call and having to handle a code blue as a psychiatrist. So we have designed with leadership from Tanu, Sharma, and Aliyah, a sort of a escalating complexity code blue. And we're using rapid cycle deliberate practice in rolling out that code blue training. And so we're really excited. It's in the first stages where we're training facilitators before we upskill our physicians, but I was able to run through it. And I have to say it's precise. You know, you go in there, you learn what you need to learn. And so that's why I loved your topic today, because it's right up the alley in terms of what we're doing with code blue resuscitation. I think it works really well for that particular topic. So that was my experience so far.
Zia and Emily, you guys are quiet. You guys must do this. I'd love to know your thoughts.
Well, I was thinking things that I think other people are thinking, but I'm just simpler. I was just thinking, it sounds like you need to match your debriefing to your objectives. So depending on what your objectives are, the amount of time you have with a particular group of learners and what you want to get out of it, either form of debriefing may be preferable. So if you're looking at skills-based debriefing and you have a group of learners only one time, then maybe rapid cycle deliberate practice is better. If you have a recurring group, like we sometimes do we have a acute care resuscitation program with our residents that runs several times a year, you may be able to do a combination of both depending on what the objectives of the particular session are. So I think that's very similar to what other people have been saying, just maybe dumbed down a bit.
Yeah, but it's interesting that 5 months later we can make people better leaders, right? So that's the part that I don't know is often, and that's, you know, and it's interesting with, again, anecdotally with our group, we have some very senior staff that participate in our code pinks, and you would think, oh, they don't need practice skills. Of course they need practice in their skills, right? So and if you I think you're right, what are your objectives, right? And most of our teams don't, you know, at least clinically, we find whenever we debrief clinically, we find that there's not a lot of role allocation. So that's a pretty big objective for me in my neonatal world. So let's make that part of it, because if I can hammer that home, that's not a skill, but for me, it's a skill that needs to be applied clinically. So I do like this sort of broadening my thought process. It doesn't just make people better at chest compressions, right? It may be entering into different realms, which I thought was interesting, which is, and maybe that's how you give that feedback. But you know, staff want more practice and feedback, right? And it's interesting to me that might translate to confidence / teamwork / leadership. Not saying this study proves it. It's just, it's interesting to me.
Sounds like there's a research question in there.
Mm-hmm.
Emily?
Hi, everybody. Thanks, Doug, for such a great presentation. We used a version of rapid cycle deliberate practice a few years ago with the implementation of a new sepsis algorithm that was being implemented across the hospital. So there was a large training program with our nurses, and we used our CDP in that. And interestingly enough, so, you know, there was great adoption afterwards, but over time, we saw a waning of adherence to that sepsis protocol, and there was a reboot or a refresh of some of the training a few years afterwards. So it is interesting around the retention piece that we found that definitely, and mind you, staff turnover, there's lots of complex reasons why you know, there may not be organizational retention over an algorithm, but that was our anecdotal experience. And then just a comment around the leadership piece. And I found it interesting because I'm like, okay, as leaders, if you have confidence in your team that they're performing the skills, perhaps that reduces your cognitive load and that allows you to be a better leader. But it's interesting from the CPR coach work that we're doing some work around that right now. And in that literature, it actually showed that it didn't reduce the leaders, like that skill piece didn't reduce cognitive load because it just got filled with something else. And so appreciating that the cognitive load of a team leader is immense. So it's interesting. Like, I wonder if in the study that you reviewed, whether like it was that finite period of time and understanding that now my team has improved skills, so I don't need to focus on that. I just some thoughts that were percolating.
Yeah, this group did produce with the same population in another paper. I found that it did reduce cognitive load, at least by the NASA tool. So to your point, that might be because your team's so good that they're taking that off of your plate, right? Yeah, I think I'm really interested in how do we improve confidence decision making, obviously in our trainees and in our teams, right? And I'd love for our nurses and RTs to take any load off of our residents, and for our residents to allow that to happen, which sometimes doesn't work, right? But this leadership improvement is interesting. I don't know, do people use this RTLE tool? I found it's Adam Cheng and Vince Grant sort of helped develop this years ago. So it's not like it's made up. It isn't typically commented on in the literature, as best as I know, but I'm not always looking at the PEDS ER piece. So it's a pretty simple tool from a leadership communication point of view. Yeah, but Roger, did you?
Yeah, thanks so much for such a great talk, Doug. And we've been talking about like how to incorporate RCDP into our interprofessional team training on our inpatient wards and ambulatory clinics. And one of the things that's been going through my mind is what you alluded to initially, that a lot of the papers speak like individual team leaders or individual professions, but like how do you extrapolate that to the interprofessional team? And so I really liked what you mentioned about staggering participants in the different cycles. And we actually do that right now, but I never kind of made that connection to link that to RCDP cycles. So that's something I'm going to take forward as a potential strategy as well. But one thing that I found really interesting was your comment around doing some like role-specific practice stations before the scenario. And I could see a lot of applications for us that as well. Like the nurses are always interested in about the preloaded epi, the residents want to learn more about the Zoll and that kind of stuff. So I'm curious, do you know if they were doing that before cycle one, or were they doing that before each relevant cycle?
Yeah, that's like the first 10 minutes when people come, they sign in, they split off, because it helps achieve a lot of their own uni-professional learning objectives. Like it might be a student person come with an experienced staff, and so they could just sort of keep themselves busy and go over a skill set that's very relevant. So we do it before we start cycle one.
Yeah.
And that seems to, again, we're trying to do many things at once with this, but it has worked for us, again, with our learners. And I think people have said this, and Zia said this especially, what are your learners and what is your team's objectives? And for those of us who've done it for a while, we might switch strategies actually during a sim, or pick up on a advocacy or an AI piece afterwards. Like I sometimes do that. I'm like, I'm curious, I saw you do this in cycle 4, right? That type of switch. But I think this, again, I encourage you all to practice it and to try it out and to keep experimenting with it. The reality is, like many things, nothing worked perfectly in isolation. It's usually a blend that works, right? And if we know the cognitive cognitive profiles and needs of our learners will always be good, all right? Or they should improve. But I'd love more work and research on that to make sure we're on the right track.
Yeah. Great, thanks a lot.
Any other comments, compliments?
Negative or positive?
Constructive.
Constructive, yeah, constructive.
Emily.
I'm only going to add this because I just got triggered a thought triggered.
Hopefully you're not triggered, Emily.
No, a thought triggered.
Okay, thought trigger. Okay.
And your discussion, and we did a study a few years back with Catherine Walsh around just-in-time training, and the just-in-time training was just before interprofessional code blue team training, and it was related to skills. So they did medication practice and CPR practice a couple of hours prior to their team training. And what we found in that study was that because they had an opportunity to practice and receive feedback on their skills, our interprofessional team training, then the debriefs start to focus more on the non-technical skills and really talk about team behaviors and performance. So it's just interesting, like there's different techniques to get you to different places. And perhaps, if you really want to focus on non-technical skills, can you parcel out the technical skills, get people the opportunity to practice that, reduce their cognitive load that way, and then get them into an interprofessional team training? Or is it better to have everyone together and do RCDP and improve people's technical skills? It's different approaches. Just a thought.
Yeah, we need better real-time monitoring of our performance, right? To identify our real weaknesses and then move forward, right? And that technology is there, and it's done in many ORs around the North America, but and frankly, it's available to, at least from a primitive point of view, in many resuscitation areas, including trauma. But it'd be interesting to know, like, are compressions as good as we think they are, or is our leadership role assignment as good as we think it is? And relying on people's memories or clinical debriefing, which is better than nothing, obviously, is ultimately the way to go, I think. Well, maybe that's it. Well, again, I'd just like to thank my sim team for helping change the way we do codes in our Code Pink Florida, just a push for all of that. So thanks again. Oh, there's a comment.
Yeah, Pamela is saying, as a representative of the Family Advisory Network at Sick Kids, your mention of parents as partners in your opening remark is appreciated and extremely valuable. Education and access to simulation for parents and caregivers is very limited. And as a lay community of partners, inclusion of parents and caregivers is important when it comes to Mindshare. Thank you.
No, I think we all need to continue to push that envelope. We do regular activity in our open bay and ICU units, and we of course tell the families what we're doing so that they know what's happening, and they very much appreciate that. And even our neonatal cuddlers, we use simulation to help train them to pick babies up and put them down. So the more family caregivers that are involved, I think it makes us better.
For sure. Thank you for wrapping us up on that positive note. Thank you, Doug, and congratulations to you and your team for this publication.
I didn't publish this, by the way, but
Tim thinks you're a star, and you are.
Yeah.
Does anybody have any parting comments? I think we're getting some applause from Elaine, who thinks you did an excellent job. Thank you so much for starting this off. I wanted to say that we're going to aim to have our SimCity rounds more frequently. Walter says, thanks for this great discussion and overview. We're hoping to run our SimCity rounds at least every 2 months. I'm going to send a sign-up sheet for the new year, so look out for our flyers advertising the next one. I've planted a bug in Agnes and Fahad's ear, so they might be kicking off the new year with Sunnybrook's innovations and simulation. And I want to thank everyone for making the time to come today. And I wish you all a wonderful holiday season, and I'll see you in the new year.
Thanks, Beto. Thanks, guys. Nice to see everybody.
Everyone, thanks, Bill.
Bye.